Today we are going to hear something different. How a 9-year-old kid gets all these things. Let's listen to Professor Deepthi.
Something that you don't often see. This is about a little kid who is only 1 year and 2 months when he came to us. Parents are from Delhi, and the presenting complaint was that the mother told us that she has noticed enlargement of the phallus of the baby and that there is some pubic hair development. These were the main complaints of the baby. And the history goes back when the baby was, the pubic hair development was first noticed around 7-8 months, where the mother did not take any notice of, but with time that it got worse. Seen by the GP couple of times and reassured the patient. But when the phallus started increasing in size, and because the pubic hair was getting more, much more than before, that she got alarmed and came to us. So she was a product of a non-consanguineous marriage with a normal vaginal delivery with a 2.79 kilogram birth weight, and there were no perinatal complications. There have been some concern about the antenatal scan about abnormalities of the kidney. Therefore, she had a postnatal ultrasound scan of the abdomen plus the head. And in that ultrasound scan, they queried there could be a cystic mass. Not much details were available to us, which was querying an arachnoid cyst. She's been asked to follow up on this, and if necessary to do MRI later. But since the baby was developing well and no concerns for the mother, she didn't pursue with any further investigations or follow up on this matter. Until such time when she first noticed the pubic hair, that she saw the GP, reassured, and when the symptoms are getting worse, she came to us. So he was a normal kid, developing very well, immunized fully, and the social background is such that they were from low socio-economic class. The father was a driver, mother was a housewife, and when we examined this kid, his height and the weight was above the 2 standard deviation. Head circumference was between the 50th centile and the 75th centile. He was a well-looking, active little kid. There were no hyperpigmented patches noted, and the system examination did not reveal any abnormality, and there were no masses on the abdomen. When we looked at the genitalia, there was pubic hair, and it was very few and long and straight hair. You will understand why I describe the pubic hair, because in pubertal development, then you look at the nature of the pubic hair when you are staging your puberty. So this was not curled hair, and it was sparse, and at the base of the penis only, which tells us, if you put it onto the Tanner stages chart of the assessment of puberty, he belonged to the pubertal development of Tanner stage 2, which I will talk to you in a little while. And definite enlargement of the penis was about 7 centimeter size, and it was definitely bigger than for a 1-year-old kid. Scrotum was not pigmented or darkening, and the testes was enlarged. We assessed the testicular size with a very objective measurement, which I'll show you a picture, which we call a orchidometer. and the pediatric endocrinologist did this for us. I personally don't have a oculometer carrying with me, and she said the testicular volume is 5 milliliter, which is into the puberty. Pre-pubertal testicular size is only 3 ml. So when you look at the external genitalia, he was definitely onto the puberty early, which we call precocious puberty. And the staging of the puberty was Tanner stage 2. This is not our kid, but I am illustrating the fact that this is the type of genitalia the baby had with penile enlargement, testicular enlargement, and pubic hair. Before we get on to what is precocious puberty, for the benefit of the students, I will touch on what the normal process of puberty is. It is the transition from the childhood to a sexually mature adult. And the initial hormonal changes is through the activation of hypothalamic pituitary gonadal axis, which we call HPG axis. And development of secondary sexual characteristic in a girl, it would be breast enlargement, changes in the genitalia, development of pubic hair, growth spurt, pubertal growth spurt, which we call, the development of body odor and acne, and of course your psychological and emotional link up with the attainment of puberty and adolescence. If we are going to call something precocious, we need to know what is the normal age to attain puberty. And for a girl, it is 8 to 13 is the pubertal age. Anything before 8 years we call precocious, anything later than 13 we call delayed puberty. In a boy, it is from 9 to 14. So hormonal changes at the onset of puberty, this is the first sign of that the puberty has been initiated. The hypothalamus secretes DNRH in pulses. In turn, there is from the anterior pituitary, there is pulsatile increase in the LHRH. And this pulsatile secretion of LHRH at the very onset of puberty is only in the night, nocturne. And with time, as the puberty advances, the changes, the pulsatile increase in LH becomes during day and night, and towards menarche, there is no diurnal variation. Throughout the day that there is pulsatile LH, and there is FSH secretion also. What are the physical changes occurring at the time of puberty? The pubic hair development, the material of whether you are a girl or a boy, will be staged according to the hair development. You will see that stage 1 is pre-pubertal, no pubic hair. Stage 2 sparse, straight hair, which our little kid had. Stage 3 is more darker, coarse curling of hair, which extends upwards and laterally. And stage 4, hair of a dull consistency. Stage 5 is hair spread to the medial aspects of the thigh. So our patient was here. Then the breast development in a girl, pre-pubertal, no breast bud, just a little small breast bud only. Stage 1, that you can see a more definitive breast tissue. Stage 3, further enlargement with the areola being formed. Stage 4, the areola and the nipple molds out of the other rest of the contour of the breast. And stage 5 is the mature breast, where only the nipple juts out from the rest of the contour of the breast. So the penile and testicular enlargement again takes a similar picture lengthening of penis, further length and the circumference. So our patient was somewhere here, even the circumference was enlarged as well as the length, and then the development of gland, penis and the adult genitalia. So this is what we call the orchidometer, which will give the volume of the testes. You compare the patient's testes with these little beads, and usually the prepubertal is up to 3, and it's 3 ml on a prepubertal child. Early puberty would be 4 to 6, and our patient's testicular size was in keeping with 5 ml from the orchidometer. So what is precocious is before 8 years in a girl or before 9 years in a boy. What are the types of precocious puberty? It could be the normal puberty coming early. If that is the case, the normal sequence of pubertal changes, which is the activation of the hypothalamic pituitary gonadal axis, will take place early, which we call GnRH dependent puberty or true precocious puberty. So central or true precocious puberty is GnRH dependent, and if it is GnRH dependent, then you have a peripheral where the hypothalamic pituitary gonadal axis is not activated, but for some reason you have the sex hormones being secreted and human chorionic gonadotrophin being secreted from somewhere else rather than from the influence from the top, then you call it pseudo-precocious puberty or peripheral precocious puberty. Then you also have another entity which we call incomplete precocious puberty, where only one component of the pubertal changes takes place. So central precocious puberty, as I said, the pubertal development occurs at an early stage. The same pattern and the sequence occurs as in a normal puberty. And it is about 5 to 10 times commoner in girls than boys, although our patient was a boy, and it is GnRH dependent. So what are the causes of central precocious puberty? You will see in boys about 50%, half of them are idiopathic, half of them are due to some other reason. But in girls, the proportion of idiopathic cases are much more. About 70 to 80% are idiopathic in girls. So when the precocious puberty occurs in a boy, you tend to look more for an underlying cause than in a girl. So what is the commonest underlying cause for the hypothalamus to get activated? It is the hypothalamic hamartoma. These are little congenital defects, and the most common type cause is this central precocious puberty, and they just lie, they don't grow, and they don't cause any pressure symptoms. It's a very benign tumor. So it doesn't really have to come out. So this is the commonest benign tumor cause in the central precocious puberty, but less commonly more malignant other brain tumors in and around the hypothalamus, gliomas, craniopharyngiomas, ependymomas, and so on can cause central precocious puberty. Other than the brain tumors, you also can have other reasons why the hypothalamus could get activated, and some of them are arachnoid cyst, hydrocephalus, radiation, trauma, and infection. So we talked about the central precocious puberty. What about the peripheral precocious puberty? I said it is GnRH independent, inappropriate sex hormone secretion, or that we have administered either excess estrogen or testosterone, At the LH-FSH level, the gonadotrophin levels are pre-pubertal, but the sex hormones are increased in quantity and may present with some or all of the physical changes of the puberty. So what are the causes of peripheral precocious puberty or pseudo-precocious puberty in boys? Congenital adrenal hyperplasia is one of the important conditions that you need to think of, where you go on looking for 17-hydroxyprogesterone level and any teratomas, virilizing tumors. So it is the sex hormones are coming from another source other than the activation of HPG axis. In girls, we need to think of this condition which has cathode patches and polyostatic fibrous dysplasia, McCune-Albright syndrome. Incomplete precocious puberty is where either you get only the breast development, which is called premature telarche, and pubertal hair development only, or just the menstruation, and they don't progress into the puberty, and you just follow them up and don't do anything much about them. So these are the investigations that you need to do. Your gonadotrophin levels would be high, FSH level, LH, and you also do a GnRH stimulation test and see the response of the LH, which will be pubertal, bone age would be advanced, and you, even in a girl, although it is 70 to 80% idiopathic, it would be best that you do a neuroimaging to find out whether there is underlying tumor or any other cause. So coming back to our little kid, Astathenula, who was in Tanner stage 2 pubertal development, we did these investigations. And these were the results we got. FSH was very high, LH was very high, testosterone levels were very high. We did not do any GnRH stimulation test because the FSH, LH levels were definitely in pubertal range and the patient had symptoms. This is the X-ray of the left hand of the little kid who was only 12 months, 14 months old when he came to us, and the radiologist used what we call the bone age atlas, where they have for different ages the X-ray of the left wrist. And this is a picture from their atlas, and our baby's X-ray was comparable for a 28 months old baby. So the bone age was definitely advanced in this situation. So we have said in boys 50 to 60% is only idiopathic, the rest are underlying lesion. Therefore we did a MRI and this is what we found. A cystic lesion in the prechiasmatic, a well-defined lesion with cystic and soft tissue component in the suprasellar region, minimally displacing the pituitary stalk and the optic chiasma anteriorly, likely to be a prechiasmatic craniopharyngioma. So the radiologist was very convinced that this is a craniopharyngioma. And the radiologists were not convinced that this is arachnoid cyst, nor they saw any arachnoid cyst anywhere else. So we presume whatever the arachnoid cyst he had regressed, and this is something new. So what is the treatment? Craniopharyngiomas has several options. If it is causing any pressure symptoms, hydrocephalus, midline shift pressure on the optic chiasma, you may do a total resection. But to do that, the age has to be right. This patient was very young for a transsphenoidal approach and was not causing any pressure symptoms to our knowledge. He didn't have any visual field defect, very obvious visual field defect, no any hydrocephalus, no any pressure symptoms. So seen by the neurosurgeon, and they felt probably that they will keep a very careful watch on the patient, and as the patient grows, if there are any indication that they will go in and remove it. So the resection could be fully total resection or partial resection followed by radiotherapy. Again, for radiotherapy, the patient's age has to be right, and this is a very young kid. So we are not contemplating either the surgery or radiotherapy immediately, but we are going to follow up on how this tumor is going to behave very carefully. What about arrest in the puberty? We need to do something. This patient was Tanner stage 2, and how we do that? You recall your hormonal changes of puberty. It is the pulsatile LH secretion and the pulsatile DNRH secretion. And if you give a sustained DNRH, it suppresses the HPG axis, right? So that is the basis of the DNRH analogs being used for the treatment of precocious puberty, right? So we have to give this DNRH analogs, which is given every 4 weekly until the time where we want the patient to attain his puberty, that is around 9 years. So he had his first subcutaneous injection of the DNRH analog, the Soladex, 3.6 milligram last week, which is a very expensive drug. One vial costs 22,800, and the chairman very kindly agreed that he will continue to supply this medication free of charge for this patient. So we will have the patient with us throughout, and we will come back to you and give an update in a couple of months' time. What is the progress of the puberty and what are we going to do about his radiotherapy. So management option, as I said, total resection or limited surgery followed by radiotherapy, which we are not going to do as it is, but this patient may need it in future. Thank you very much.
How do you arrest the artificial process in some item?
Yes, now when we suppress the gonadotropin and the sex hormone, the bone age will also get in line. We don't give anything specific. We just suppress the puberty glucose. So it was just about the 2 standard deviation. Adult height won't be that bad.
And notice we have done an ultrasound scan of the brain at 2 months. What are the reasons?
Because the antenatal scan has shown some renal abnormality. But I don't know, then you would do a postnatal renal scan. By brain, we couldn't really get any information.
Madam, is there a age limit, like all patients who are diagnosed as precocious puberty, are they treated or this?
They have to be treated.
Even at 8 boy, 8 year
If it is 8 years, perhaps depending on how advanced the bone age, you might wait. If it is stage 2, because the adult height, you have to be very cautious if the growth spurt.
Prolactin there's usually disturbances in the
Prolactin
hypothalamic pituitary axis
If I might be able to help me
causes
out.
changes in the prolactin even without the prolactin. Yes, that is.
Prolactin doesn't cause precocious puberty. It can
No, I
cause
mean for the-
amenorrhea.
No, because the lesion here is a craniopharyngeal lesion of the hypothalamic pituitary axis. So any tumor in that vicinity, it usually causes changes in the prolactin level.
I think it is definitely a separate entity. It doesn't have any relationship with the pubertal process. Any questions? Students need to go and brush up your normal pubertal development, sinus aging, and a little bit on precocious puberty.
Sorry, but has
Yeah.
this kind of thing been described in the literature from Sri Lanka before?
I think there have been a couple of cases, but we are going to report as well. I'm not sure whether craniopharyngioma and precocious puberty in a boy has been, because mostly it is hypothalamic hamartoma. Okay.
So thank you very much for that.